So let's evaluate here about our ionizing radiation and how it affects our tissues and cells. We know that we use ionizing radiation in many different modalities, including like X-ray and CT and mammo. We are then taking these same types of photons within radiation therapy, but we have just accelerated the energy of it. So we increase the energy of it. We're just talking about the overall potential of it to travel through the body. And so some are going to penetrate deeper, some are going to be a little bit more superficial, depending on the actual acceleration capabilities that we caused. Because we have different levels of beams. We have like 6 MeV beam, 8 MeV beam, 10, and we can do others as well. So let's talk about our linear energy transfer, or LET. So that's going to be referencing the amount of energy that is transferred into the tissues, into the body, as it is being used. So the x-rays that we use in like x-ray and CT and mammo, also we're going to include gamma rays, which are what we produce with our normal external beam radiation therapy. Those are about 3 keV, which is also kiloelectron volts per micron. So yes, we are delivering some, but because it tends to pass through the body, because it's a higher energy, that means that it's transferring less to the patient. So we call those a low LET. Now, particles, when I'm thinking about particles, I'm referring to things like alpha particles, which are going to be your protons and your neutrons together. We do also do proton therapy in rad therapy. So with those protons, they are a bigger particle, and when they interact with the tissues, they are more likely to deliver that radiation to the tissue rather than passing through. Those larger structures just cannot make it through the body. So when they deliver their radiation, we say that they are high LET because they can deliver anywhere from 30 to 100 kiloelectron volts per micron. So we're seeing at least 10 to a lot more times greater than we would have had with just our gamma rays. Now, relative biological effectiveness, or RBE, is looking at the biological effect caused by the radiation. So what effects are we going to have on the tissues? How much damage are we going to do because of that radiation source? So as we get a higher LET, we're also going to increase or have a higher RBE because we are increasing that, the amount that's delivered to the patient. Versus lower LET, gamma rays are going to pass through the body more likely. So it will deliver some, but it's not going to cause as much damage. Here are two good demonstrations to identify our LET and our RBE. So low energy transfer is demonstrated up here, meaning that it is going to continue to pass through the patient, meaning that it's going to deposit less energy as it's moving through because it is capable of passing through. Versus high LET, there's going to be more deposit of energy, so all of this is staying inside the patient and not making it through. So more damage is done with that high LET. Then we look over at our biological effectiveness. So our LET is on the bottom and then RBE is going up. So as we increase our biological or our LET, that means that we get more of our radiobiological effectiveness. So increase your LET means you're going to be using like particles, like more I'm referring to like proton therapy. So as we increase the proton therapy, that is going to increase the biological effectiveness and it's going to kill more cells. Breaking it down even further, when the radiation interacts with the body, if we look on the DNA level, we are going to see that there is DNA damage that will vary depending on what type of protein there was involvement, and then also the type of radiation that was used. So changes in sequence for the proteins can happen. So basically what occurs there is the proteins like alternate in the wrong spot. So if that happens, usually it's minor as long as it can repair itself, because usually DNA can kind of see that something is out of whack and it'll fix itself. But sometimes our body doesn't pick up on that. And so if it doesn't, then it's major, because if you get your proteins out of sync, then it's going to create different things throughout your body that you didn't necessarily need or want. And maybe it's not doing a job anymore that it should have been. If we have a single strand break, those are much easier to repair because it was done by lower energy transfer radiation. So the single, remember, strand breaks with the lower LET, that's going to be for like your x-rays, that's for utilized x-ray CT mammo, and then also the gamma rays with external beam. So what you're seeing is right here is going to be that single strand break, okay? And then this over here could have been when your proteins get out of sequence, so they kind of pull apart, and then when they're pulled apart, they come back together, but they're not in the right spot. And then a double strand break is a lot harder for your body to repair. So the DNA struggles like, okay, well, where does this end line up with this end, and making sure the proteins are in the right line. So it is much harder to do to repair itself, and those are usually going to be caused by higher LET. So those are ones that the protons are going to come in, they're going to interact with the body, and it's going to cause some major damage. So needless to say, the higher LET, the protons are going to cause more damage throughout the body, and they're more likely to cause the double strand break. Lower LET doesn't cause nearly as much, and it's going to cause mainly single strand, if any at all. We want to make sure that we understand what's happening at the cellular level as well. So when we have the radiation that is absorbed and we take in that energy, it can cause damage to the cell membrane itself. So remember, the cell is going to have a membrane around the outside that's going to help prevent things from just entering and exiting without like just cause. Like it has to be a certain thing to come in and out. If we have that cell that's damaged, so now let's say that there's a hole in the wall, that'd be a structural issue where things are just open and out. So you might even lose some things that were from the cell that just escaped out. Then you also could just have damage to that cell where the process of allowing things in and out of the cell stops working. So that would be a functional issue. And we don't want some things to come in and we don't want some things to go out. So we got to make sure that those stay in accordance with what they are supposed to be. Now, so a couple of things that affect the susceptibility or the radiosensitivity of our structures is that our cells are going to respond better to the radiation when they are well oxygenated. So we definitely want our tumor to be oxygenated. So that way, when the radiation comes in, it is more likely to cause cell death. We want that for the tumor. Another thing is that our cells are more susceptible to that radiation when they're actively in mitosis or they're in the G2 phase. So let's look at this little diagram here. So over here we have the cell cycle. So one thing I'll point out here is that G0, that is where the cells go when they say, okay, I'm done replicating and I don't need to do anything else right now. I'm just going to kind of stay static. That's like your skin. So your skin is like constantly replicating, but we don't have usually an overgrowth of skin, right? So once it reaches a certain number of cells that it needs to reach, it goes into G0 phase. So that way it stops replicating. Otherwise, we'd have like 12 different layers of skin constantly reproducing itself. Okay. So then if we are going to go into the replication process, we have G1, where we're going to be prepping and growing. G is usually referring to growing and changing the cell how we need to prepare for the next part. S is actually going to be the synthesis phase where things are truly being copied. So we're copying our DNA. And then G2 is where it's growing again. We're really, really replicating. We've already had our DNA that's copied. Now we're just growing based on that DNA and what it's telling us to do. So, and then after that, we actually go through mitosis where it's going to split off into the two cells. So we see that G2, that second growth phase, and then the mitosis phase, when it actually splits, is where we see the most radiosensitivity. Why? We already have our DNA that's replicated. And so at that point, when we cause any damage right then and there, it's automatically going to be replicated right afterwards. And so then if we get stuck in that cycle of, oh, I just replicated and my DNA is broken, I'm going to go through the cell cycle again and have that same problem again and again and again. So G2 is typically where we see that, and mitosis. We have some different radiation effects that we'll cover here. So we have somatic effects, and those are the kind of radiological, biological effects that are going to happen within that individual. So things that are happening to the person itself. So early effects are going to be caused by your cell death. And so things that you're going to see along those lines are nausea and vomiting, and fatigue. Fatigue's like the biggest one for everyone, but the rest of them kind of depend on the location. So nausea and vomiting, that's going to be associated with like intestinal issues because of treatment to the intestine. So if we're treating somewhere by the small bowel or the large bowel, the rectum, that can cause some issues there. Erythema is going to be another common one, and so that's going to be the reddening of the skin, kind of like a sunburn, which you can see on this patient over here. And so the redness here, and this one's not bad at all. Some patients, because they have sensitive skin, it will get very, very red and sometimes even blister by the end of their treatment, but it will go back to normal. It just takes just like a sunburn, it just takes a little bit to kind of heal up from the process, and we'll give them some cream to help with that. Epilation is actually going to be that peeling that you get from a sunburn. You get that with erythema as well. Blood disorders, so we can affect the amount of blood cells that are within the body because we are just causing cell death in whatever area we are treating. And there's blood vessels in all the areas we are treating typically. I already mentioned intestinal disorders. Fever, occasionally, if we are doing a lot, especially to the blood areas, if it affects their white blood cells and it affects just overall what's going on, it may make the body work overtime, kind of like when you're sick. So when your body's working overtime, you can get a fever. Dry and moist desquamation. So those are some skin irritations where the dry desquamation is kind of like eczema, like really, really dry skin that's like starting to peel off more than just like erythema, but really starting to peel off. And then we have moist desquamation, and that's usually like between crevices where we see that it's almost like a blister kind of that's kind of ripping and tearing at the skin. Almost like an ulcer, yeah. So definitely not something that we want to see, but occasionally, depending on the body part that we're treating, we can. So we can get them medications or different types of things to put on their skin to help with these conditions. So those first ones were early somatic effects that occur, and then now we can talk more about the late uh, systems that we can have issues with. So these are going to be long-term results because of our radiation exposure. And so the biggest one we think of is going to be our carcinogenesis. And so carcinogenesis is where we see cancers that occur because of the mutations of the cells. Because the radiation damaged the DNA, it has now started to replicate and continues to replicate of different cells that are not correct. And that's what cancer is. So as you can see here, this breaks down some mutations that could lead to cancer, but they're very, very small over time. So it's like a small, tiny little break in the DNA that didn't really cause any issues. But then the next cell cycle, it's a little bit different even then. And then we get even more different. And then by the time that you truly discover it, it could turn into a cancer cell. So this happens over time. It's just the wear and tear from radiation on our bodies. Um, the hard part is that we can't 100% always lead it back to, yes, it was this that caused it, because there's so many other causes of cancer out there. Our diet, what we surround ourselves with, our environment. So there's so many things that we take medications for, we put on our skin, fragrances, so many things that could affect our cells just as much as the radiation could have as well. So hard to lead back to 100% for certain saying that it was the radiation that they got it from with our late effects. Another thing is genetic effects. So we can see, so no longer somatic, but genetic. These ones happen in the future generations. So passing it down to the offspring. Okay. And this happens because there's been damage to the DNA within a sperm or an ova. And so when the actual process occurs where fertilization occurs and one of them is damaged somehow, or maybe both of them, it is now going to pass down damaged cells, which can then lead to issues with formation of the fetus. And so that patient could end up with something like hemophilia. So that baby would mean that they are excessive bleeders. They don't have like all the clotting properties that our normal people do. Could end up with Down syndrome, muscular dystrophy, sickle cell anemia, cystic fibrosis, hydrocephalus, and those are only just a few. There's so many things out there that could occur because of this. But again, it's so hard to decide if it's 100% was caused by the radiation that they were exposed to or something else throughout their life. Our overall goal of radiation therapy is going to be to eradicate certain tissues, specifically like the tumor, the cancer, while also minimizing the dose to the surrounding structures. So, very similar to what we think about within X ray and CT is a LARA, right? As low as reasonably achievable. So, we're trying to do the opposite here and do as high as reasonably achievable to the cancer while still sparing the surrounding structures. Because we're still going to cause some damage to healthy cells. It's impossible not to. So our dose is given in what we call daily fractions of a whole dose. So if you think about that you have a fraction. Let me get my little marker here. Okay. So if I'm saying that out of one whole week, we are going to have 5 days of treatments. That is 5 fractions. Okay. But the whole dose that we were given was 5 out of 5. So when we add all 5 of them together, we're going to get 100% of the dose. So then whatever 100% is, obviously divided by 5, going to be 20. So every day they're getting 20% of their total dose. So that's why we call them fractions. So we can give anywhere from just one or a few fractions or days of treatment to up to 6 weeks. Our daily dose is typically going to be 180 or to 200 centigrade. That is a very common dosing for just standard normal cancers. If we do something like hyperfractionation, hyper meaning more than normal, so more than the daily dose, we then are going to do 2 or 3 times that normal daily dose. So they could come back twice a day, or once in the morning, once at lunch, and once in the afternoon for 3 times. Now, if we do hypofractionation, this is going to be a very, very large dose over just a few days. So instead of coming for 6 weeks, they may come for like 7 or 8 days. And so we will increase the amount of dose they receive at each of those fractions. And that's all based on research and what they see as acceptable and what's probably not going to hurt the cells around the tumor any more than normal. So we don't want to cause any more damage than we have to. We have repopulation and redistribution. So our normal cells will repopulate. So going back to our skin cells. So when we lose some of our normal skin cells just because they have gone so many days and they need to come off, just due to just normal factors, they're going to come off like when we're in the shower or on our clothes or on our sheets in our bed, and we don't even really notice it, right? But we always have a layer of skin underneath it because our skin knows that it needs to repopulate to make up for what's going to be coming off soon. Our tumor cells are likely to die. Some will not be sensitive, and therefore we won't be able to kill all of them in one go. So we have to use fractionation to try and kill it, but also give it a little bit of time to repopulate anything that it might have missed. Okay. So that's why we do it every day, because your cells can repopulate some within a day. So whatever we missed from the previous time, we can try and kill this next time. And again, it does it every single day for a certain amount of dose. We're trying to just catch as many cancer cells in the different divisions as possible because they're not always going to be going through G2 or mitosis when we interact with them. They're not always going to be perfectly oxygenated every time that we treat. So we're trying to spread it out over a series of days so that hopefully we can catch them at multiple phases. Here are some examples of our fractionation. So a standard fractionation means that a patient is treated once a day, Monday through Friday, for up to 6 weeks, so usually 4 to 6 weeks. and their daily dose is going to be 180 to 200 centigrade, meaning that their total overall dose is about 45 to 50 gray, and that's really common for breast cancers. Hyperfractionation is we can do this with accelerated with normal dosing. So what that means is they're going to be treated more than once a day, Monday through Friday, usually for 2-3 weeks, depending on their days and like when they started. But their daily dose is going to be 360 to 400 centigrade. So they have a lot more dose, but it is still spread out over certain hours. So they may come twice a day, so morning and then in the late afternoon, or they come 3 times, morning, lunch, and afternoon. So they're still getting a total of 45 to 50 gray, just faster. And so that's used sometimes for certain cancers. The physician that I worked with, he did not like hyperfractionation. Just depends on the doctor. Hypofractionation is we're using less treatments with higher dosing. So they're still only coming once a day. We're not doing more than once, only once, Monday through Friday. And that's, again, up to 2 to 4 weeks. But our daily dose that we're giving at that one time per day is higher. So it's going to be greater than 200 centigrade. It varies depending on the person, but they're still going to get that total dose of 45 to 50 gray. So kind of switching it up here a little bit, kind of showing you just the possibilities. There's been a lot of studies out there with hypofractionation with there being positive outcomes. It's like less side effects for the patient while they're still receiving treatment. So they're getting it at the tail end of their treatment, those side effects, and so it doesn't delay their treatment. Versus if you did the full 6 weeks, they may even have to take a break in between at like 3 weeks because they're starting to see some bad side effects and they're struggling to come to treatment. We also have something called stereotactic body radiotherapy or stereotactic radiosurgery. Both of these are extremely high levels of radiation given over just a few days or even once. So, body radiotherapy is usually given up to like 5 days, so 1 week. And they use a daily dose at about 10 gray. So let's rephrase that. We had been giving 180 to 200 centigrade in one treatment, and now we're giving 10 gray. That's a lot. Okay. But so if we give it over 5 days, we still get up to that 50 gray. These are very specific cases, and they're very hard to set up for because you have to be absolutely perfect. Typically, the doctor is watching your every move, and then you have to get a sign-off clearance before you can actually expose and beam on for the patient because it's so serious how much radiation you're giving. And then radiosurgery is even crazier. So radiosurgery, sometimes they actually do this within surgery. So if a patient's getting brain surgery and they're trying to remove an area or they just want to treat it as close as possible, they can have radiation therapy while they're under. And so they can deliver that high dose of radiation in one time. I have done radiosurgery a couple times, not in the surgical atmosphere, but just in a regular environment for external beam. And it was only one treatment. And it was very scary for me, just being because it only happened when I was a student. And it was early on in my clinical experience. And they had a patient that had brain cancer and they were trying to give it everything that they got. So they delivered all 40 some gray in one treatment. And so it was just like a high stress environment. I think once you get more used to it, it's not scary. But being in that situation, knowing that they cannot be off like at all, it has to be really, really perfect as best as possible. So I think they repositioned an image like 4 times to make sure that everything was as close as possible before they delivered that 40 gray. So I don't say that to scare you. It's just more of a high stress environment. I mean, it's kind of like when you are in a trauma scenario, you go in, everybody's looking at you when you're trying to do your chest x-ray or your pelvis, and there's so much going on. So that's kind of a similar environment. It was just nerve-wracking because I was a student and it was my first one. So something to think about there for our different types of fractionation. Here I have a chart that kind of outlines what we call our tolerance doses. So there has been a lot of research out there about how much radiation certain body parts or organs could receive, and that within 5 years, there was very minimal complications. So they found out what that dose was for a large majority of people, and they made a template or, these kind of suggestions on thresholds, or we call them tolerance doses. So If you want to shorten that, most times we call it TD55s. So, what dose within 5 years has minimal complication rates? Okay. They can deliver these as whole organs. So, if you do the entire bladder, for instance, they could receive up to a dose of 60 gray and still have minimal complications within the next 5 years. But if you did a partial of the bladder, so let's say only 1/3 of the bladder was exposed, you could increase that. So it could be a higher dose, maybe like 70 something gray. Um, and it still have minimal complications because you only exposed a small portion of it. So these are some common ones to think about. Bladder is 60, esophagus is 60, muscle is 60. The ovaries are only about 2 to 3. The rectum is 60, uterus is 75, bone marrow is 2.5, the brain is about 50 to 60, eye is 55 to 70, heart is 45, and intestines is about 45. So main ones we were always told to memorize were bladder, esophagus, rectum, muscle, brain, and intestines. Those were big ones for us during rad therapy school. You'll see this again, but this is what we call a dose volume histogram. So this is going to be this graph that's going to outline the dosages of all the organs that we're exposing in our beam path, as well as the tumor volume. So our dosimetrist is going to create a plan based on what we are trying to expose, okay, or trying to treat. And so the radiation oncologist prescription and also what the TD55s are, they're going to try and match that or less if possible. We want to make sure we try and do as little amount of radiation to those organs as we can. So once it's finished with its treatment plan, it's going to outline all of this in this dose volume histogram. So these over here, these ones are showing the actual tumor volume. So where we're treating that we really want to receive that dose, and it's high, and that's good. That's what we want. Then over time, we're going to see as things like the heart, the right lung, spinal cord, rib, normal liver, and the left lung are all also receiving dose, but we're trying to keep them under their dose in centigrade. So if you have 3,000 centigrade, that's 30 gray. So that's just kind of a demonstration of how to look at a dose volume histogram and see what it's referring to. We want all the normal organs to fall down here. We don't want them to have much. So with the early somatic, I wrote these out again. Things we can start to see after the first week: fatigue, erythema, swelling or inflammation along with that erythema if it gets kind of, sensitive. Dry, wet desquamation, loss of appetite, especially for patients that are having pain in their esophagus. Alopecia is going to be where we start to lose our hair. Nausea, vomiting, and diarrhea, again, if we're treating anything in the intestinal region. And then atrophy or necrosis, meaning something that is dying, so of the healthy tissue. So healthy tissue is dying off because we have exposed it with more than we would have liked. Late somatic is obviously the cancer. A few common ones would be leukemia, affecting the blood, breast carcinoma, affecting the breast tissue surrounding maybe where we treated another breast cancer, thyroid carcinoma, if we're treating somewhere in the head and neck or even breast, and then osteosarcoma is affecting more of like the bone marrow and the bones. Genetic effects, again, we have that possible mutations. I kind of talked about those before. You could have hemophilia, Down syndrome, muscular dystrophy, all of those different things that occur. And here's just some more pictures to show you. I wanted to show you with alopecia, we don't make patients lose their hair like chemotherapy does. Chemo typically makes them lose all of their hair with certain medications because it is a systemic type of treatment where it goes all throughout their body. So anywhere on your body, you could lose hair. With radiation therapy, it's only in the local area where we treated. So if you have a brain tumor and we are treating from the front, it's still going to have to penetrate through the back as well. So you're going to see that you're losing hair in the front in a kind of circular fashion and then also in the back. If we treated multiple spots, like with this patient, you may lose hair in those regions, but you're not just going to lose over the entire thing. This patient over here has erythema, so reddening up for that head and neck treatment that she's had. This would be like that epilation, sometimes a little bit like dry desquamation as well. So you have that peeling off. Usually dry desquamation's worse than this. This is just kind of like the coming off of a sunburn. Then down here is what I meant by wet desquamation. So underneath this breast tissue, it has rubbed up against the abdomen and it has caused more of like a blister or ulcer sensation. So that skin is tearing and causing damage, but it's also kind of moist in that area because of the location of it. So we do have some things we can help with these patients. They put kind of like a gauze pad down here to prevent any friction. We can give them medications if they're itchy. We can give them medications if they're in pain. We do recommend they use things like Aquaphor on their skin to help build a positive barrier to prevent erythema and worsening of dry and wet desquamation.